So I will give a very brief introduction, just showing some of the research that we have done, and that creates a little bit of the foundation for Taylor's project that she will explain in detail. So our research project concentrates on personalizing care in heart failure, but having an accurate estimate of prognosis. So if we can define personalized medicine, it is understood that personalized medicines try to endeavor to customize, the care plan to maximize absolute benefits of a specific intervention based on specific patient characteristics, considering patients' values and preferences. One way of personalized medicine is to customize the care plan based on a patient risk. For example, low-risk patients may choose not to take a medication that is associated with a small absolute benefit, because this patient may place more or higher importance of avoiding the risk associated with that intervention. While the opposite could happen in a high-risk patients, where the patient would take any risk associated with the medications to maximize the benefit, given that this medication may provide significant absolute benefit. One of the key aspects of this type of personalized medicine is to have an accurate assessment of prognosis, especially in interventions that are costly, associated with significant risk, or can have also limited resources. So how do we predict prognosis in heart failure? The standard of care is based on our own judgment. But there are options, such as Adam was saying, in diagnosis. So there are many models that are developed, that are out there, that can provide accurate prognostic information. So one of our research questions in our program was, what is showing here is, are predicted models more accurate than physicians to predict one-year mortality in ambulatory patients with heart failure? So we did this study that compared model predictions versus physician intuition, we call it, or physician judgment. So we conducted a prospective cohort study. We enrolled around 1,600 heart failure patients, followed at 11 heart function clinics across 5 provinces in Canada. At the time of enrollment, we calculated their predicted mortality based on different existing conventional predicted models, such as the Seattle heart failure model. And we also asked family doctors and heart failure cardiologists to estimate the risk of these patients dying at 1 year based on a percentage from 0 to 100%. We followed these patients for 1 year and collected their mortality. At the end of follow-up, what we observed is that the Seattle heart failure model that is marked in red in the upper graph show very good accuracy by comparing the predicted mortality to the observed mortality, which is the green line. The C statistic of this model was 0.76, which showing good discrimination, but as shown in the graph, more importantly, was very accurate. When we compare the predicted accuracy of heart failure doctors and family doctors, we observed that they also have good discrimination, so they were able to say to differentiate patients who were not going to do well from those ones who were going to do well, but the calibration was bad. I'm using Adam's adjective here. So the physicians, both family doctors and heart failure cardiologists, tend to overestimate risk from low to very high risk patients. In a secondary analysis, we try to assess, evaluate patients' characteristics and physicians' characteristics associated with physician inaccuracies. And the most interesting finding that we observed was that the inaccuracies of physicians tend to be much higher when the risk of our patients was higher as well. And that led to Taylor's project, that we took a magnifier, and now we are evaluating accuracy of physicians to prognosticate outcomes in patients with advanced heart failure. And I leave Taylor to show you.
Hi, everyone. So as Dr. Alba just mentioned, so based on the findings from this work, we wanted to evaluate model accuracy in this subset of high-risk patients who we considered as advanced heart failure patients being considered for advanced heart failure therapies at UHN. I was clicking the wrong green button. So as we know, many patients with heart failure will continue to progress despite optimal clinical management. Such patients with advanced heart failure are often considered for advanced therapies, including ventricular assist device and heart transplantation, which aim to prevent further decline, improve quality of life, and overall survival. Given the increasing global prevalence of heart failure, as well as the aging population, an increasing number of patients require these therapies. These therapies are, however, costly, associated with serious risks and complications, and donor organs are limited. Therefore, it is essential to select patients who will realize the greatest survival benefit and intervene at the optimal time. So given the clinical complexity of these patients, evaluating prognosis for advanced heart failure patients is challenging. During the evaluation process, heart failure patients undergo a series of medical and psychosocial assessments that inform their estimated survival prognosis. These assessments, placed in the context of guideline recommendations, are what ultimately determine the decisions of whether patients require and could benefit from advanced heart failure interventions. Currently, medical decisions on the appropriateness and timing of these interventions relies on the informed judgment of multidisciplinary medical care teams. Risk prediction models may offer valuable support to physicians in this setting. These models, however, have not been all developed for advanced heart failure patients, and there's uncertainty regarding their prognostic utility in this setting. So the objectives of our study were to evaluate the accuracy of the Seattle heart failure model and the MAGIC score among advanced heart failure patients undergoing assessment for advanced heart failure therapies at UHN, and also to evaluate the relationship between patient prognosis and the medical decisions made at the end of the assessment. So our retrospective cohort study included just over 1,000 patients with advanced heart failure who underwent this assessment at UHN between 2005 and 2021. We collected information obtained during the assessment for advanced therapies and calculated the predicted one-year mortality risk using both the Seattle heart failure model and the MAGIC score. We also collected the medical decisions made by the care team for each patient at the end of their assessment. We classified these decisions into 3 groups. The first being patients who were considered candidates for advanced therapies, so they were either listed for transplant or provided a date for VAD implantation. Patients who were considered too well for advanced therapy, so this included patients who improved on medical therapy. And the third were patients who were considered too sick for advanced therapies. So these included patients who had some problem that precluded them from candidacy, and also included such as medical or psychosocial contraindications. This also included patients with reluctance towards advanced therapy, among other reasons. And we also grouped patients who died during their assessment into this category. We also collected each patient's mortality status following the start of their assessment. So of the 1,084 patients included in this study, 37% were considered candidates for advanced therapies. Now, in the 33% of patients deemed too well and 30% of patients deemed too sick, so both groups who did not undergo advanced heart failure therapies, we assessed the discrimination and calibration of both models using Cox proportional hazard models. We also reported the proportion of patients in different decision groups across predicted risk deciles. So just quickly, before moving into the study results, I'll go over 2 terms that are important for understanding the upcoming results. So these are the discrimination and calibration of a risk model, which together reflect how well a particular model generates an accurate prognostic estimate. So model discrimination refers to how well a model is able to differentiate people at higher risk of having an event from those at lower risk of having an event, and is typically reported using a C statistic where a value of 0.5 is equivalent to chance or flipping a coin, and a value of 1 indicates perfect performance. The second measure is calibration, which informs how similar the predicted absolute risk is to the true or observed risk for patients classified in different risk strata. So if we look at the calibration plot shown here, we can see that the model predicted one-year mortality, which is indicated by the orangey line, is very similar to the observed mortality for patients in the lower risk setting, but the model starts to underestimate risk for patients at higher risk, so who have a predicted mortality greater than about 30%. And this is important to consider as patients with a model predicted risk of 30% in fact had an observed mortality of closer to 40 or 50% in this example, which would have important implications in the decision-making process. So for example, choosing whether or not to defer heart transplantation. So for a risk model to be considered useful, it should have adequate discrimination and calibration. So overall, the accuracy of both models was limited in our group of advanced heart failure patients as compared to the performance in the general heart failure population Dr. Alba previously showed. So discrimination was limited in both models, and calibration had some inaccuracies with risk underestimation for lower risk patients and overestimation of risk among higher risk patients. Here we can see the proportion of patients across medical decision groups for each risk category as defined by the Seattle Heart Failure Model. And along the x-axis, we have also provided the observed one-year mortality in brackets for each risk category. So if we look at the lowest risk category that had an observed mortality around 9%, we see that about 30% of patients were deemed candidates, and about 20% of patients were deemed too sick, when in fact these patients had a low risk. Among the highest risk categories, with observed mortality between 20 to 30%, we see that many patients were considered too well for advanced therapies despite having a high predicted risk. These data demonstrate some inaccuracies in clinical assessment of prognosis and possible improvements of care through the use of predicted model-guided decision-making. So while the prognostic accuracy of the Seattle Heart Failure Model and the MAGIC score remain limited, these models were still able to discriminate to some extent patients who did and did not die at 1 year. When looking at the decisions made by the medical team, according to the observed risk of mortality, we observed some misclassifications with an important proportion of low-risk patients undergoing a heart transplant or VAD that was likely premature. The findings from this study demonstrate the potential role that risk models may serve during the assessment for advanced heart failure therapies. Before doing so, however, we need to develop a risk model with improved prognostic performance, developed using a more representative data, as well as potentially more sophisticated methods, such as machine learning. Such models would help to improve shared decision-making with regards to assessment and decisions around advanced heart failure therapies. Thank you.